Excuse me.
Okay. Perfect. Thank you, Tom, for the introduction. Very happy to be here. Thank you all for waking up early at 7 o'clock to come and be part of this presentation. I've been here for 6 weeks, so I'm still trying to get to know my way around. So, everybody has been very supportive, very welcoming. So thank you very much for that. I appreciate it. This is a lecture that, some people may not be familiar with all the information that I'll be presenting today. And so it would be a good way to get kind of maybe an idea of what's going on in the world of melanoma and also in the world of cancer care in the United States. The way so I tried to split the presentation into two major sections. One is about melanoma, and the other one is mostly about just an update on how we're doing with managing cancer patients in the United States. So let's see. So melanoma, as you all know, is a skin cancer. The good news, it's not the most common skin cancer. Basal cell cancer is still the most common, with more than 4 million cases a year. Melanoma and Merkel cell tend to be the most aggressive type of skin cancer, and it tend to be the more life-threatening than the other one because it tend to have distant metastasis and also is not as sometimes responsive to the therapy that we usually do for something like basal cell and squamous cell. Approximately 100,000 cases per year of melanoma is diagnosed in the US. As far as where melanoma is, as far as cancer, so this here on the left is shows the chart that shows the new cancer cases in the US. These are the top 10. And as you can see, melanoma is the number 5 cancer in men and also in women, with approximately 6% in men, 4% in women. So it's not that uncommon. It's actually more common than things like leukemia and pancreas cancer, for example. And at the bottom, we see the top 10 reason or causes of mortality from cancer. And as you see, melanoma is not one of the top 10 mortality, which is a good news. And the main reason behind that is because melanoma is most commonly diagnosed as an early stage, and it has a good prognosis, and so it doesn't make it to the top 10 causes of death. The problem that melanoma has been going up, so the number of cases and the rate, the incidence rate of having melanoma has increased over the years. As you can see, it's almost double. Now the lifetime probability of getting melanoma is 1 in 41 in women and 1 in 28 in men in their lifetime. So it's a common problem. So, it's still considered not as common as maybe prostate and breast cancer, but still a common problem in oncology. Now, I know most people here is probably in internal medicine, or there's a lot of residents here. And, it's very important to recognize melanoma. I didn't realize can we get rid of, oh, okay. I didn't know you can get rid of that. So it's very important to recognize melanoma early on, as I said. And one of the problems we face is that melanoma can sometimes look like a mole or a nevus, a benign nevus. And One of the things that we do with melanoma is to differentiate melanoma from a benign nevus is the ABCDE criteria. This is not perfect, and so I can't tell you the number of times I've seen patients who went on for many years thinking that whatever looked like a benign mole or nevus was actually a melanoma after a biopsy was done. So A is looking for symmetry. So anything that is symmetrical tend to be more consistent with benign disease or benign nevus. B is for borders. Uneven borders is a suggestion of melanoma. Coloring or colors, different colors within the mole could be a sign of melanoma. The size, anything larger than ½ inch, also is, could suggest melanoma. And E for evolving or evolution. And it's actually one of the most important things, which is the changing over time, changing in the size, shape, or color of a mole over time, what we really rely on for the most part. Now, if we just, in this presentation, I'm trying to start from the basic, just the common things about melanoma and knowledge about melanoma. So even if you've never seen a melanoma patient, you can just follow and get most of the information I'm presenting. So if you remember the skin consists of two major components on the top, which is the epidermis and the dermis. Melanoma is the cancer of the melanocytes. Melanocytes are the cells that are in the epidermis. These are the cells that protect us from sun exposure, and so it resists sun UV lights. As far as staging, the most important two things about melanoma when we stage it is how thick the melanoma is and if it's ulcerated or not. As you can see here, we use the T staging. It goes from T1 to T4, and it goes technically by thickness, how thick in the skin the melanoma is. If melanoma has ulceration, it's also a bad prognostic factor, something we see under the microscope, not something you see, on the patient's skin. The way we stage melanoma is we use the T&M staging, T for the primary skin melanoma, and for the nodes, and then for the distant disease or metastasis. Now, you don't have to memorize that. I have to look it up every time I see a patient. It's very complicated, but I think what I would tell you is there are a few things I would probably just try to focus on. As far as prognosis, the most important two factors is how thick and if it's ulcerated the melanoma is. If melanoma is stage 1, then it's a great prognosis, greater than 95% patient alive at 10 years. And they don't need to see an oncologist. We usually refer them to see a dermatologist and follow up with derm. Anytime there's melanoma in the lymph nodes, that's considered a stage 3 melanoma. And anytime we have stage 2 or 3 melanoma, then we consider doing systemic preventative therapy after surgery. So that's kind of a straightforward kind of guideline to help you know what stage and what the patient needs. Now, melanoma is not always, a lot of people connect melanoma to sun exposure, but it's not always the case. We see melanoma in unusual places, and there are some unusual melanomas. I'll just mention 3 types of these unusual melanoma. Acrolentigous melanoma is a melanoma that's start on the palm and soles or under the nail bed. It's usually less than 3% of patients, and it usually happens in patients with dark skin. Mucosal melanoma is another one that is rare. It's probably 1%. We see it in the oral nasal cavity, sinuses, vaginal, anorectal melanoma. The problem with mucosal melanoma, it has a bad prognosis. It doesn't respond to the treatment we have as well as cutaneous melanoma. And then we have the last one, which is uveal or choroidal melanoma. This is the melanoma that starts in the back of the eye, not on the surface here. And usually this is treated with what we call radiation plaques inserted in the eye. It tends to metastasize to the liver, and also systemic therapy is not a great option for this disease. Still, the standard treatment for melanoma continues, or early melanoma continues to be surgery, although there are a lot of emphasis now on systemic therapy and the role of systemic therapy in melanoma. However, surgery tends still to be the upfront treatment that we have. For surgery, we'll have three types of surgeries that we consider for patients. The first type is wide local excision. Wide local excision is after the patient has a biopsy showing melanoma. The pathology report comes back from the biopsy showing melanoma. Wide local excision is taking a little more skin around that biopsy site. Usually the recommendation is up to 2 centimeters around that site. And it could be a little less than that in areas where, like the head and neck area, where 2 centimeters all around cannot be done. This is usually done, and this is the surgery for thin melanoma. So it has to be less than 0.8 millimeter and no ulcerated. Now, if it's not, then we do wide local excision and a sentinel node biopsy. Sentinel node biopsy is a procedure done by our surgical oncologist colleagues. This is where we follow the lymphatic drainage from that biopsy site, and we remove a few. It can be anywhere between 1 to, I've seen, as far as high as 5 or 6 lymph nodes from a sentinel lymph node biopsy. And this is where the lymphatic drainage from that site goes first in that lymph node basin. The third type of surgery is what we call, I don't know if we can move. Oh, we can, okay. The third type of surgery is what we call elective lymph node dissection. When we did the lymph node biopsy and the lymph node came back positive for melanoma, it used to be that we would send the patient and have what we called an elective lymph node dissection. This is when the patient gets all their lymph node removed in that lymphatic basin. Now, it turned out that that was probably not necessary. A large study looked at that, looking at, does that elective lymph node dissection helpful, or does it extend the patient's life and survival? And it turned out that it doesn't. And for that reason, we no longer offer that elective lymph node dissection, and it's no longer considered a part of the treatment. Now, 2011 is really when everything kind of changed for melanoma because of the newer treatments that we have. Before 2011, this was the survival chart. The 5-year survival, as you see here for stage 4 melanoma, was around 10%. So the likelihood of someone being alive at 5 years with metastatic melanoma was 10%. And just keep that number in mind, because I'll show you what we have now, just in comparison, historic comparison. The only options we had was chemotherapy, never improved survival, that has a very low response rate. Immunotherapy, we had what, I don't know if everybody here is pretty young, so you don't remember probably interleukin-2. This is a treatment that was given in the ICU. It was it's still a very intense therapy, has a lot of side effect, and was not very effective. Now, what happened in the last 13 years that kind of changed everything? We learned about some gene mutations in melanoma that we're able to target. Most importantly is the BRAF mutation. We have better immunotherapy. Immunotherapy is the most important treatment we have for melanoma. We have many drugs and many new targets that were found and approved. And we also improved the outcome of patients with brain metastasis, a very common problem in melanoma. And one of the very unique things that we now have, especially with immunotherapy, It used to be that for metastatic patient, for a patient with metastatic cancer, that patient would stay on treatment, be that mean chemotherapy or any other therapies for life or until death. And that's really changed with immunotherapy, because it turned out that we can now stop that treatment and patient continue to be in response and maintain that response. And so that's what we sometimes call a cure. We try not to call it a cure, but a lot of people now are heading in that direction, being alive 10 years from having stage 4 melanoma with no treatment. I'm just gonna, if you guys want to just grab chairs, please feel free. I don't want you like standing up and like passing out. So this is more like a big reception kind of setting here. So please, yeah, perfect. Now, as far as mutations and targeted therapy, it's very important to emphasize the MAP kinase pathway. This is a pathway that some melanoma tend to be dependent on to grow and to be able to survive. The most common mutation in that pathway is the BRAF mutation. It's present in 50% of patients. And that BRAF mutation is not just one type of BRAF mutation. There are different types of BRAF mutation. And for patients who have that mutation, it turned out that that melanoma is very dependent. The growth of that melanoma is very dependent on that mutation. So the question is, what if we target that mutation, what we inhibit it, would that stop the melanoma from growing? So this is the early attempt to stop or to inhibit the BRAF mutation. This is a patient at baseline, started on BRAF oral therapy, and 4 months later, patient disease is completely resolved, but 6 months later, we see the recurrence of their disease. So the problem we had, although the responses were great, we couldn't maintain that response. The patient would fail very shortly after they are responding. And the question was, what if we target more proteins in that pathway? Because one of the ways of resistance turned out to be that maybe there is overactivation of the MEK protein. So the question was, why don't we inhibit both the BRAF protein and the MEK protein and see if that's improved the outcome of the patients? So this is really what happens. We combine BRAF and MEK targeting agents, and we compare them to only BRAF targeting agent, and it's turned out to work or to work better. So the duration of response that was the problem was extended, and now it's 14 months for this. These are two different combinations. And here it's in a different combination, it was extended to almost 19 months. And so that was made a change in the way we currently treat BRAF positive patients. And although these are oral therapies, I just warn you that they still have significant side effects that we try to manage and deal with, most commonly pyrexia and other GI type of side effects. Now, this is probably the most important slide I have for you today. It reminds everybody about cancer immunity cycle. And this is really to understand how treatment for melanoma or immunotherapy for melanoma works. It's really important to understand this cancer immunity cycle. I'll walk you through it. So it starts here by cancer releasing antigens. So these are cancer cells that die and release antigen due to radiation, chemo, or cancer cells just dying on their own. And when that happens, antigen are being released. These antigen are then picked up by something we call antigen presenting cells, or in this case, dendritic cells. And that will lead to what we call priming of T cell or T lymphocyte, which usually happen on the lymph node, at the lymph nodes. So we have T cells recognizing the antigen that was presented to them, and they're being primed and activated and stimulated. These activated T cells are then released in the bloodstream, a lot of them. And from the bloodstream, they go to and infiltrate the tumor stroma. And from that, when they get to the tumor stroma, they interact with the cancer cells. So this is where the T cells start recognizing the tumor cells, and that's where the interaction is taking place. And then the T cells kill the cancer cells, and that antigen is released again, and that's the cycle starting back again. Any of these steps is a place where you can manipulate the immune system, you can change the immune response to have a more effective immune response or a more robust immune response. And that's really where immunotherapy in general in cancer is really focused on targeting these steps, or some of these steps. So when it comes to immunotherapy in cancer, the focus is especially in melanoma, is on these two steps, where the T cells are being primed and recognizing the antigen, and also when the T cells are killing the cancer cells. And these two steps are usually mediated, but what we call checkpoints or receptor, T cell receptor or checkpoint receptors. These are receptors on the T cells. So when that interaction takes place between antigen-presenting cell and the T cells, the T cell has this receptor CTLA4, and also in this phase has this receptor which is called PD-1. And all immunotherapy in melanoma is based, everything we have is based on targeting these two receptors, the CTLA4 and the PD-1. Why do we target these receptors? Because these receptors tend to self-regulate the T cells. So these receptors keep the T cells under control. They inhibit them from being overstimulated and overactivated. And so by inhibiting these receptors, you're technically taking the brake off the T cells, so they stay stimulated and activated and capable of continuing on this cycle. These are some of the drugs that we have. Ipilimumab is one of them for CTLA4, and pembrolizumab and nivolumab are the main treatment for melanoma. So this is what I was referring to. 2011 is when we have the first CTLA inhibitor approved, and that's for the first time in 2011, we have a drug that showed improvement in survival in a patient with metastatic melanoma. Follow that, we had two PD-1 inhibitors approved in 2014, and it turned out that maybe PD-1 inhibitors are actually better than CTLA4 inhibitors. So these drugs became standard of care, and as they improve the outcome and the sometimes the survival of the patients. And the question in oncology, which what we always do, is, well, let's combine things. Let's just do it all. And so that's really what happened, and it worked. So by combining inhibition of PD-1 and CTLA4, which is that line, we had the most important trial that, in melanoma, and I think in the history of melanoma. This is a trial for 900 patients almost, where we compared PD-1 plus CTLA4 compared to PD-1 alone, compared to CTLA4 alone. And the results, this is the survival in 5 years. Remember that 10% number that I mentioned initially in the previous slides? Now we're looking at 52%. So more than half the patients are alive at 5 years with the diagnosis of metastatic melanoma. And that is a very significant progress and improvement in the field. As you can see here, if you keep going and monitoring, you see that improvement continues to it's present even up to, this is the last follow-up they did, and it's maintained at 6.5 years, and it's definitely better than the the other drugs alone as single agent. Now, while we're doing that, a new checkpoint inhibitor became available. So now instead of targeting PD-1 and CTLA-4, now we have an option of targeting PD-1 and a LAG-3. So it's just another checkpoint inhibitor. And having that combination also looked like to be better than just targeting PD-1 alone. And you can see here, we were able to improve the rate of progression of melanoma progression when we use the combination therapy compared to single agent. The problem with immunotherapy is definitely we now have new side effects that we didn't have when we used chemotherapy. These side effects you probably have seen sometimes, you know, on the floors or on the service when you're on service. This is the result of overstimulating of the immune system. The immune system turn again against some of these organs. So we have, you know, could be pneumonitis, hepatitis, nephritis. Some of these side effects could be irreversible. We see patients with, for example, adrenal insufficiency, and they need replacement for life. The rate of the severe side effect, these are severe or life-threatening side effects, could be at up to 59% in some cases. So it's created a lot of you know, headache for everybody on the medical teams, oncology teams. The treatment for these side effects is based mostly on stopping the treatment and steroids for a prolonged period of time. Most patients do well. Initially, we had, you know, when we were not familiar with these side effects, we had some fatalities related to this treatment, but that's improved significantly. Now, the question is immunotherapy timing. And the question now, we saw how immunotherapy really worked well for metastatic disease. Now, can we do it for prevention? These are patients who have surgery and, you know, technically their melanoma is removed. Would it help to give them immunotherapy after that surgery? It turned out that the answer is yes. For patients with stage 3 melanoma, giving them immunotherapy for a year after their melanoma is removed improve their chances of relapse. And that became also a standard therapy. And, you know, we always like to take it a step further and say, hey, you know, if it works after surgery, why don't we just do it before surgery? And so the rationale for doing it before surgery, because technically, when you do it after surgery, you remove your antigen, you remove your melanoma. So technically, your immune response is kind of calmed down. It's not as intense as if it would be with the melanoma still being there. So the idea of giving the immunotherapy when the melanoma is still there and you still have all your activated T cells may make a difference and may be that what could change things around. So that led to two important trials that I will just mention briefly here. And this is technically comparing as I said, the before immunotherapy before surgery, which is given pembrolizumab before surgery, or doing surgery and then adjuvant therapy and then doing the pembrolizumab after surgery. And the question or the answer was that neoadjuvant is definitely better as far as relapse, but these are patients with enlarged lymph nodes. So these are advanced stage 3 melanoma. Getting immunotherapy before surgery tend to do better when it comes to relapse free survival in the long term. Now, the second trial is looking for the combination. Remember that combination, that very powerful combination? And the question was, can we just do it before surgery rather than just to do immunotherapy after surgery? And so this was a recent trial, was just published. It's unfortunately, yeah, it's just published. And it's really given 2 cycles of the combination immunotherapy before surgery. Patient would go to surgery based on their outcome, they could receive more treatment, or patient would have surgery and just receive the single agent PD-1 a treatment that is still considered standard treatment. And once again, treatment before surgery was superior and significantly better. It's also showed that patients who went to surgery, so these are patients who got 2 cycles of these two drugs, went to surgery. Impressively, 47% of those 47% of those who went to surgery had a complete pathologic response, which technically influenced the way we manage those after surgery. So that could be something that would be very beneficial in determining what kind of treatment patient get after surgery or not. So the option would be to not continue with the treatment after surgery based on the high pathologic response rate. Here you see the outcome based on the pathologic response rate. So, and you see how patient with a major pathologic response do the best when it comes to outcome. Another thing, brain metastasis in melanoma is a major problem. It turned out, the thought is that systemic therapy doesn't work for brain metastasis. And the main treatment has been always radiation and surgery. And the question, would the current newer systemic therapy work for brain metastasis? And the answer is yes, it can work. Now, keep in mind, the responses are high, but keep in mind, these are very selected patients. They may not be the typical patient that you may see on the floor who come with 15 brain mets and so on. So, but as far as concept, immunotherapy and targeted therapy still work in brain metastasis. Now, I'm just going to mention 3 novel treatments in melanoma, and that will conclude the melanoma section of the presentation. Oncolytic viruses, adoptive cell therapy, and cancer vaccines. This is the future. This is really eventually is going to open a lot of doors for patients who don't respond to everything else I showed. So TVAC is a virus, is a herpes virus that is genetically modified. And this is a treatment that is injected in the cancer, in the melanoma itself. The purpose of that treatment is to convert a cold tumor, or what we call it, a tumor that is non-inflamed, to an inflamed tumor. Remember how we need the release of that antigens to initiate or boost that immune response. So that's really what the treatment does, by injecting it directly to kill the cancer cell and release the antigen, and also secrete what we call GM-CSF, also to improve the immune response. This is kind of the response. The response is not, they're not always, impressive like this. So it's sometimes it works, sometimes it doesn't. It seemed to work better also with systemic therapy and not just alone. The second type of novel treatment is adoptive cell therapy. This is very interesting, and it has been going through testing for many, many, many years. Finally, we do have a product that is available to us. I'll walk you through how this works. So technically, we get the cancer removed, the tumor removed. That tumor, when the cancer is removed, the T cells that are attached to that cancer is isolated, and they are being expanded and grown in the lab using different things. I won't get in a lot of details. And once these are expanded, they are processed and shipped back or given back to the hospital. The patient then goes through what we call chemotherapy, lymphodepletion chemotherapy, and then given these T cells back, in sometimes billions of T cells. These are the smart T cells that were isolated from the tumor, so they can recognize the tumor and also can kill the cancer cells. When this was tested, so there has been a lot of testing, but this is the recent testing. This is in comparison to that CTLA-4 inhibitor alone. These are patients who were heavily treated. They fail a lot of treatment in the past, and they still did very well with this treatment. Some responses up to 50% response rate, 20% were complete responses. This is the product we currently have approved, and it showed to have a response rate of 36% in patient with literally not a lot of good options available for them. This treatment is not available everywhere. It's a very labor-intensive treatment, and so it may or may not be available in some centers. The last one is the vaccines, mRNA vaccines. This is kind of the results of the COVID pandemic and the spike protein, and how we can use the same technology to develop vaccines to help with killing cancers. The way the vaccine is made is technically from the tumor cells. So these are the tumor cells removed from the patients, and so these are then the mutations are identified within these tumor, and these are used to make the vaccine. We use this mutation to create what we call a neoantigen in vitro, and then we give it to the patient. This is individual made vaccine, so it's made specifically for specific patients. When this was given with a PD-1 inhibitors in patient after surgery, this was a trial that was just presented and was just published for the first time. We have a vaccine that improved the outcome or the relapse of patient with melanoma, and you see that the difference here between the PD-1 inhibitor alone versus the PD-1 plus the vaccine. That is very impressive. This could change the way we treat melanoma in the future, and so stay tuned. As far as summary for melanoma, before we get to the second part of the presentation, as I said, early diagnosis is very important. Multidisciplinary approach is really what we need and what we use between our colleagues in surgery, dermatology, and so on. Treatment before surgery seemed to be better or more effective. Targeted therapy with the BRAF mutation shows high response rate. Problem is it can stop working. Combination therapy definitely better than single agent, but definitely has more side effects. Response maintained for years after stopping treatment, which is something very impressive and new. Systemic therapy for brain mets works. The new strategy for patients who fail everything, it's still immunotherapy, but we're looking for different target, new targets. Precision is very important, meaning knowing who respond to what and what to give to each individual patients, as well as predicting side effect through genetics and precision medicine. More research is definitely needed in the less common melanoma type. And definitely cancer prevention and UV protection is definitely something we need to work better at, because that's still a big problem. How's everybody doing? Good? So the state of cancer care in 2024 is taking on my role as a division chief of HEMONC. I think it would be naive if I don't recognize the challenges that come with that role, or would come with what's happening nationwide as far as cancer care and oncology care. So the next few slides, I will be showing just some statistics, some data about what's happening when it comes to cancer care, oncologists, and some of the ideas or things that we could consider moving forward to be able to be successful and provide the best care to our patients. So this is the good news, and I think this is the only slide with good news. So it can get worse from here. So the incidence of cancer has gone down. So you can see here the incidence of cancer over 50 years or so. We were up there, and now we went down, both in men and women. And also the mortality from cancer has gone down. So this is a very good news. This is encouraging news. This is the cancer death that was or has been averted over the past 30 plus years in men, and you can see also in women, almost 2,800,000 deaths averted, and here is 1.3 million deaths averted. So that's a very good news. It's just a reflection of early detection, reflection of improving treatment, and everything else, all the tools that we currently have. Now, it's not a good news for everybody. So this is some of these problems that we have. So when it comes to disparity or inequity in cancer care and outcome, you see that different ethnic groups may not do as well. This is, for example, the mortality for some of these cancers. So, for example, for American Indians, it's 42% more likely to die from colon cancer. This, same numbers for also non-Hispanic Blacks, 34% to die from colon cancer, 40% greater chance breast cancer, and it goes all the way up to even double mortality rate for Black patients with prostate cancer. We're also it's not a great news for patient in smaller communities. So this is a comparison of metropolitan greater than 1 million, less than 1 million, and also non-metropolitan area. And if you see the incidence, not just the incidence, but also the mortality goes up. These are two examples of colon and lung cancer. So there is a 38% higher likely of dying from lung cancer if someone just lives in a non-metropolitan area. So just where you live determine your outcome, how well you do from cancer, and also more likely to get cancer. So you're more likely to get cancer, and you're more likely to die from that cancer if you live in a small town. Now, it's also not a good news for New York, although the annual rate per 100,000 has gone down for the United States. That drop has not been as big as we see in New York. So we're still above the average as far as new cancer cases. So we're at 471. The national average is 439. Now it gets even worse. So if we look more at specific counties, we see that most of these incidents of cancer is really located in central and western New York. The darker the blue color, the higher the incidence rate is. And as you see in the United States, we're looking for 44 per 100,000, New York for 65. Once we get to our counties here, north and south of us, we're looking at numbers of 546 for Oswego County. Clinical trial is one of the most important things in oncology, and putting patient on trial is a goal for most oncologists, most cancer centers, but we're still not doing a good job at that. More than 90% of patients don't go on a trial. More than half of the patients don't have an available trial. And approximately 70% of the US counties lack any single trials. If you look in more specific to non-metro county, you get 86% of the counties without any trial. So there's no trials available in 86% of non-metro counties. So that's something that we always have to keep in mind. Make sure we're doing a good job as far as cancer care. So cancer incidence is down, but the cost is definitely up. This is just an estimate from Medicare data. So this is, patient just diagnosed with cancer at some point in between 2000 and 2012, and just looking at the cost projection for 2030. And as you see, the cost goes up significantly. This is for all sites, and it goes more than 50% for a lot of different cancers. Now, you may say, you know, where are the oncologists? And the answer to that is, you know, we have way more demand and we don't have enough supply. We have a national shortage. This is a prediction from ASCO, the American Society of Clinical Oncology, from 2007, predicting for 2020, predicting at least 2,500 to 4,000 shortage of oncologists. They did the same thing again in 2014 and predicted approximately 19,000 shortage. I'm sorry, the shortage to be 2,300, but the total position to be 19,000. Now, if you can see here, so even that projection for 2025, for almost 2025 of 19,000, this is where we are now. We are at 16,000, so we are even behind projection. We're still having this age gap that we have less or 37% of our oncologists are less than 64 years old, and so we need to consider also the possibility of retirement and other things like that. Recruitment has become very difficult, and you know, if you're graduating, if you're a fellow, if you're doing a fellowship, if you started getting job offers, I just tell you, you know, just be careful with those, because in this environment, there could be a lot of these kind of deceiving offers in a way. I get them every day, every week. This is a sample of something I got last week. Hematology oncology in Ohio, up to $1 million. Now, that's not true. You're not going to make $1 million. So just make sure you consider your option really, really well when you start looking for jobs. Now, if the shortage was not enough, patients or oncologists are also leaving patient care. This is a big study looking at more than 16,000 oncologists, surgical oncologists, and so on. 1 in 5 oncologists have left CMS billing practice between 2015 and 2022. And you may say, well, maybe these are folks who are retiring. Maybe these are, you know, people who just worked so many years and they don't want to work anymore. However, we see that oncologists with only 10-year experience, 8% of them quit or stop seeing patients. 9% of those with 10 to 20 years of experience. Looking at a random sample of these oncologists, it looks like 35% of those who left got another job. And that job was in pharmaceutical and biotechnology. And the estimate is that 1 in 17 oncologists may be changing jobs. Burnout is a real problem. I know we're short on time, but burnout is getting worse in oncology, and I'm assuming in a lot of other divisions and specialties. It's not a unique problem to oncology. One or more symptom of burnout has gone up from 34% in 2013 to 2023 to 59%. Keep in mind the national average is 48, so half the physicians have some kind of burnout already. The burden of electronic medical records, I don't think we're really doing a good job. We could do better. I think we could focus more on spending more time with patients. This is based on many hours of following physician in different practices, and it turned out that the time spent with the patient face-to-face is only 27% of what we do. 49% is spent on medical records and other things. That's just to show that oncologists even get more messages through electronic medical records compared to other specialties. High patient expectation is an issue. So it's not that we have all these problems, but also our patients sometimes can be demanding, and they want the best care available. This is a This is a 2-page list of questions that the American Cancer Society have for patients to ask their oncologist or their cancer center where they go when they go see him for the first time. And you can see from these questions, like, where can you use your cell phone? Or is this a teaching hospital? How would that affect my care? And so you can see, like, this is what the recommendations are for the patient to discuss what they, and they're probably valid, but it just shows you more that the demand from the patient has also increased or gone up. So again, I think these are some of the challenges that we all have to keep in mind as physicians, especially as oncologists. You know, we have some major problem with the small metro area. The rural cancer care needs to be addressed, you know, and specific needs need to be addressed for that population. Patient access is very important. If we don't improve access, if we don't get the patient to see us, there's no point of doing what we're doing. We have more and more demanding patients, so that's something we have to figure out a way how to work with or around. We have patients living longer, so we have more patients. We need more survivorship care, making sure patients disconnect from their oncologist and maybe see other specialists. We have more and more complex therapy and more costly therapy. We try to focus on specialty oncology care. So this is what's unique to us compared to what's happening in the community. We have to definitely consider and keep in mind the shortage of oncologists and very, you know, the difficulty of recruitment. Research and needs to be also focused with what we do. I believe this is my last slide. I will just say that, you know, this is the future of cancer care with a focus on Upstate. Definitely, as far as patient care, we need to continue to provide that superior specialized care, multidisciplinary care. We need to build these program of excellence, you know, promote clinical trial, the culture of clinical trial, and getting more patients on trial. As far as the community, we definitely are responsible to our, you know, for our community and reaching out to the community and their cancer care. Program specific with a specific focus of community care needs to be considered. As far as physician, I think we've shown enough. I think we need some more programs to manage things like recruitment, burnout, as well as making sure we are providing our physicians, especially our young ones, with the adequate promotion, mentorship, and also coaching, and also help them with promotion when time comes for promotion. It's 8 o'clock. I will stop here. Thank you very much. These are my contact information. I know I won't be able to respond to a lot of questions due to time, but if you have any questions, please reach out, and thank you. I'm happy to take maybe like if people are waiting. Okay, then we're good. Thank you.
Dr. Thompson, she's not here.
We didn't record it, did we?
We did. We're gonna set it up.
Oh, okay, perfect.